So now we're going to go look at EKGs and pathologies of heart conduction. So EKGs basically reflect how the heart is conducting, what part of the heart is conducting. So the P wave is for depolarization of the atria. So that's when the atria will contract. And next is the PR interval. This is the interval spanning the beginning of atrial polarization all the way to the start of ventricular polarization, because ventricular polarization is seen by this QRS complex. Now the normal is less than 200. That's a number to remember and memorize. PR interval normal is less than 200 milliseconds. QRS complex, as we mentioned, represents depolarization of the ventricles. So when it's depolarizing, it's starting to squeeze. And this is normally less than 120 milliseconds, so it's pretty narrow. So you want your QRS complex to be narrow. Remember that number as well, 120 milliseconds. Finally, T wave is for ventricular repolarization. And finally, the QT interval, which can be altered by a variety of pathologies, is normally less than 440 milliseconds in men and less than 460 milliseconds in women. Now there's a quick and easy way to determine the QT interval. And what you do is, let's say there's another EKG. I'm going to draw over everything here and do a poor EKG. So this is the QRS. So you want to look, you take one QRS and you look at the QT. And you want this QT to be less than 1/2 of this whole segment, from the R to R segment. If it's less than 1/2, then your QT interval is usually normal. That's a clinical pearl for you. It's a quick and easy way, because you're gonna have to adjust adjusted QT interval, which is not relevant for our step purposes, but it's relevant in real life. So now let's get into pathology of heart conduction. First pathology is atrial fibrillation. So to fibrillate means it's almost like a quivering of the muscle. So it's quivering of the atrial muscle. And what you're going to see here is super characteristics, the irregularly irregular RR interval. So your RR intervals are going to be irregular. That is, they're not going to be coming in regular, nicely timed intervals. You see this one and this one are different lengths, and then this one and this one are different lengths. So they're irregular, and the irregularities occur. They're not a very predictable irregularity. They're non-predictable, so we call them irregularly irregular RR intervals. Now I said the atrial muscle is fibrillating. So what you're going to happen is you're going to have chaotic rhythm and a super fast atrial rate, and it's so fast that you can't really discern P waves. It's just a quiver. It's fibrillating. It's quivering. Okay. Now the AV node refractory period, remember the AV node was the gatekeeper. That's going to determine the rate of ventricular contraction. So the atrial contraction is very quickly, but as the conduction travels down to the AV node, remember that one conducts slow, so it's going to be the gatekeeper, and it's going to determine which impulses from the atria are going to reach the ventricles. And you can have sometimes very fast ventricular response, and that's called atrial fibrillation with rapid ventricular response, RVR. That's when you get a tachycardia, tachyarrhythmia, where your ventriculars are beating faster than 100 beats per minute. Remember, greater than 100 beats per minute is tachycardia. Or actually, we're going to cover this later, so I'll talk about that later. So what's going to happen is you're not going to have any coordinated contraction in the atria. Remember, it's just quivering around and blood is just like flopping around. And so you're at very high risk of blood clots. And especially you're going to have blood clots in this atrial appendage right here. So you're going to have blood clots because there's blood stasis. And this clot can eventually go into the ventricle and eventually shoot out of the heart into the rest of the body. So that's what's going to happen there. You're going to get thromboembolic events. So do you remember what are examples of thromboembolic events? Remember, stroke's a big one because the blood clot can go to the brain. It can go to anywhere. It can go to your kidneys and cause blood clots there. It can go anywhere and cause problems. Next one is atrial flutter. So I think a flutter kind of like a bird fluttering its wings. So you're gonna see this regular sawtooth P waves. So that's really easy. You see this, you know it's atrial flutter. It's just fluttering around like that. Okay, nothing more needed to say. Ventricular fibrillation. This is fibrillation or quivering of the ventricles. So again, when it's quivering, it's disordered. There's no organized contractions. So there's no, it's not organized. So blood is not coming out of the heart very well. So this is a very life-threatening disease. Actually, you need immediate CPR and defibrillation. So that's when you do the electric shocks of the heart, and that's to get its contractions organized again. If you don't do that, it's going to be fatal because your heart's just like quivering and no blood is actually coming out to perfuse the rest of your body. Again, on EKG, there's no identifiable waves. It's just this weird up and down little quivering of the heart. Alright, next we're going to talk about AV block. So atrioventricular block. So this is when you have problems with your atrioventricular node. First degree AV block, it's basically a prolonged PR interval. That's all it is. That means your PR interval is greater than 200 seconds. That's because your AV node, remember that one has slow conduction, it's too slow. And we can see here the PR interval here is over 200 milliseconds, longer than what you would expect. Now this is asymptomatic and no treatment is needed. Second degree AV block, and this is termed Mobitz type 1. There's two Mobitz, Mobitz type 1 and Mobitz type 2 for second degree block. In Mobitz type 1, your PR interval will lengthen. So you see at first it's short, then it gets longer, and it's going to lengthen with each beat until a beat is dropped. This keeps lengthening. Eventually you have this P, but there's no QRS. Where is the QRS? There's no QRS, it got dropped. And then you start again with a short one, and it's going to lengthen and lengthen. That's Mobitz type 1. Now Mobitz type 2 is similar, but the difference is your PR interval length does not change. So you still have drop beats, but you see this PR interval, same, and then drop, and then where's the QRS? Okay? So Mobitz type 1 lengthens with the beat dropped. Mobitz type 2, PR interval length does not change. Now they put this here, this 2-to-1 block, secondary AV block, because with this type of block you can't tell if it's Mobitz type 1 or Mobitz type 2. First of all, this 2-to-1, what does this mean? That means for every 2 P waves you get 1 QRS. So 1 P wave, 2 P wave, 1 QRS. So it's 2-to-1. Now notice you only have 1 P wave for QRS before you drop one, so you can't tell if it was lengthening or not because you only have one example. So that's the 2-to-1 block. Finally, third degree block. This is a complete AV block. That means there's no association at all between P waves and QRS complexes. Remember, P waves are atrial contraction and QRS complex is ventricular, and the AV node is between those two. So it's complete AV atrioventricular block. The atrial ventricles are beating independently. So what happens? There's no association at all between the P waves and then the QRS. QRS goes by themselves. They don't follow each other. They're just doing their own thing. Okay. Now next is additional arrhythmias. This is torsade de pointe. I don't know if I'm saying it right. Honestly, in my mind I say torsade de pointes. And this is a type of ventricular tachycardia, so it's tachycardia. That means your heart's beating too fast. And you have varying amplitudes of the QRS that forms a sinusoidal pattern. So remember, a sine wave is like this one. This is a sine wave here. So that's what it looks like. You're getting this sinusoidal pattern up here. Or you can even do it like that. The sinusoidal pattern of your QRS interval. That's torsade de pointe. That usually occurs in patients with the long QT interval. Remember, it was a normal QT. Remember, for guys it was for 40 milliseconds or less. For women it was for 60 milliseconds or less. And this is bad news because this can progress to ventricular fibrillation. Remember, we just talked about that. That's when your ventricles are quivering and you're not having organized contractions. And remember, that's life-threatening. So that's bad news. So going on more about the QT interval. There's something called a congenital long QT interval. So you're born with defects that cause you to have a long QT interval. And these are inherited disorders, usually due to defects in the ion channels of the myocardial cells. So those ion channels are what cause your heart to polarize and depolarize. And so if you have problems with that, then you can have a long QT interval, which is a problem with polarization as well as depolarization of the heart. These patients are predisposed to syncopal episodes. Remember what syncope means? That means sudden fainting and sudden cardiac death, and that's due to torsade de pointes, because what do we say that torsade de pointes can lead to? Can lead to ventricular fibrillation. Remember, that's life fatal. So that's like 3 things in one that we know about. There's 2 types of syndromes that we want to remember. There's Romano-Ward syndrome. This is autosomal dominant, and there's no deafness. And then there's Jervell and Lange-Nielsen syndrome. This is autosomal recessive, and there's neurosensory deafness. So these are opposite of each other. And I remember this one because deaf is 4 letters. 4 letters. And guess what else is 4? What else is 4? Well, this whole name is 4 words. If you remove the dash, that is. So Jervell and Lange-Nielsen. So that's how I remember. This one is the one with deafness. Romano-Ward has no deafness, and it's autosomal dominant. So that, one more pathology is the WolffParkinsonWhite Syndrome. This one is basically you have an accessory pathway. So remember how we said normally you start at the SA node and you go to the atria, then you go through this whole pathway down the middle. Remember what it was? Remember it was the AV node. What happens next? It's the AV bundle of His. Then you go to the left and right bundle branches. Then you go to the Purkinje fibers, and finally you get to the ventricles. In this case, we have a little shortcut here. Now remember, this shortcut only shows the arrows in this way, but it can actually go both ways. So you can shortcut depolarization from the atria to the ventricles. And then likewise, you can see in this picture, it can go the other way. And that's why you can get a little circuit here. You can get a re-entry circuit that's going to get polarization really quickly, okay? And that can lead to a tachycardia. So tachycardia is when your heart's beating too fast. And they term it supraventricular because the origin is supraventricular. It's from the atria, which are above the ventricles. Now, as I mentioned before, atria can send signals directly to the ventricles by passing the AV node, and the ventricles are depolarize early, and you're going to get that characteristic delta wave, because this delta, remember, QRS is where your ventricles are depolarizing, and if it's depolarizing early, it's going to shoot up a little bit earlier, and that's what you get a delta wave from. Okay, so delta wave is characteristic of WolffParkinsonWhite syndrome. It's very characteristic. So if you see that, you know the diagnosis already. Skip that. Again, arrhythmias. Bradycardia is less than 60 beats per minute. Tachycardia is greater than 100 beats per minute. We're going to talk about tachycardia more. Bradycardia, not as relevant for step 1. And even note that even people can have less than like heartbeats of 40 or 50, especially really, really conditioned athletes. And that's totally normal. So we're going to continue this differential diagnosis of tachycardia in the next video. This is not as relevant for step 1, but it's very relevant clinically. I like it a lot. I like the way I think about it, so check it out if you want to. Alright, so that's it for our arrhythmias.